can't see or smell, you know, maybe a ovarian cancer or something. I don't know what it is, but I don't want to send her home. Can I send her to you? So I said, sure. So he puts her in a helicopter and sends her to Oklahoma City. And when I see her, she is exactly as advertised. Low-grade abdominal pain, can't really localize it. Abdominal exam normal. Send her to CT scan to confirm the CT scan, which I shouldn't have done, thank you very much. But I did, and it was the same, a little bit of fluid down in the pelvis. Someone should have told me I couldn't do it. I don't know what I did, because I'm an idiot. So I put her to bed and said, we'll talk to you in the morning. And so I came in the next morning, and she said, oh man, this pain's getting a lot worse. It's been really bad since 4 o'clock. So I pulled the blanket back, I raised up her gown, and I listened, and there are no bowel sounds, none. I can't hear a thing. And every time I touch her belly, she's screaming in pain. She has rebound tenderness, which we'll get to in a minute, but she has no bowel sounds, and her belly's rigid. It feels about like trying to push on this table. Okay, I'll get back to that in a minute. High-pitched tinkling sounds. You have to hear it to really know what this feels like. It's literally like you're hearing water dripping over a little waterfall. Tinkle, tinkle. It's real high-pitched. Tinkle, 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 tinkle. And it's caused by ileus. It's caused by the bowel sort of laying there still, and water, the fluids inside the small bowel is, by gravity, kind of falling down over stacks of dilated bowel. High-pitched tinkling sounds. If you get a patient in your clinic or in the hospital that has a real low potassium, before you replete it, go listen to their belly. They commonly have an ileus, and you commonly can hear these high-pitched tinkling bowel sounds. And then bruits are the same as bruits in the neck or bruits in the rib. It's just turbulent blood flow through an artery. Those top two would be the renal arteries. The middle two would be the iliac arteries, and then down below would be the femoral arteries. Although, if you have a significant bruit in the abdomen, you can probably hear it everywhere. So this is mostly for the exam. Renal, iliac, femorals. Percussion is to be used to distinguish tympany from dullness. Nothing on the physical exam is more difficult to learn to distinguish between, in my opinion. Nothing. So here's how you do it. When you're sitting at home studying naked, common, right? You reach down over your thigh and percuss over your thigh, and listen carefully to what that sounds like. And then you reach up and percuss over your chest, and listen to what that sounds like. And compare those two resonant sounds. One is over a solid and one is over air, right? One's dull and one's timpani, like a timpani drum. That's where the word comes from. And there's no other way to describe it except to just do it and experience it, okay? So when we're trying to figure out how big the liver is, one of the ways we do it is to percuss, and we get up here above where we think the top of the liver is, and we start percussing down. And when we hear the resonance change, we mark it with a pin. And then we go down to the belly and we start percussing up, and we mark it again and then, once we've done that, that's coming up from the bottom. Try to avoid those, whatever they are in the middle there. And you measure it. You have to have a tape measure, because you want to know how many centimeters the span of the liver is, and it needs to be done in the mid-clavicular line. As you know, the liver is going to be a different shape, different in the abdomen. So we always measure the liver span in the mid-clavicular line. Now the scratch test, in my opinion, is so much better than the percussion test that when I try to figure out what size the liver is, I always use the scratch test. And this is the way this one's done. You got to do this a lot of times too to make it, to figure it out. You put your stethoscope anywhere you want over where you're going to be working. So right sort of toward the bottom of the chest cavity, or over the ribs is fine with me. And then you get up here where you're above the superior edge of the liver, and you start scratching. You're scratching so that there's a continuous sound. Not, that won't work. It has to be a continuous sound. And when you hit that upper edge of the liver, that sound will change pitch. It'll go boop. It'll be dramatic. And it's more dramatic than picking it up when you're percussing. The only way I can be sure when I'm percussing that I'm at the liver edge is if I think I'm there, then I spread two fingers on either side of it and compare. And then I'm pretty sure. But with the scratch test, I'm sure I'm there. And you do the same thing from the bottom. You just leave your stethoscope where you are and you scratch continuously. And boop, it'll the frequency of that sound will pop up. You can also use that test to figure out where and how big a pleural effusion is, because you're scratching over air, and as you scratch down, you hit that water, which is like a solid, and the frequency goes up. It's a great test. Yeah.
Do you do this on clothes or without clothes?
No clothes. For my word, for my money, you never do the physical exam over clothes. Ever. Ever. It's the 11th commandment. Thou shalt not auscultate the lungs through clothing. Triple F 0 if you're in my clinic. Triple F 0 is your grade if you're listening to the lungs. Why would I say that? Because I'm a dirty old man and I want to see everyone with their clothes off? Why do I say that? Do it yourself. Take your stethoscope and listen to your lungs on skin, and then listen to your lungs with your shirt on. Two things happen. Through the clothing, the sounds are muffled dramatically. Secondly, if you're listening through the clothes, and you're taking a deep breath, with certain kinds of clothing, it can sound just like Ralph's. It can sound just like Ralph's. So, no clothing. This is always on the skin. The clothing would also, I think, interfere with the maneuvers. So, yeah, no clothes on this deal. Everyone clear on the percussion and the scratch test? Any other questions?
You said that the pitch will go up when you hit the liver?
The frequency goes up. I don't know what that means exactly, except that's true, from a physics standpoint, the frequency of that sound is increased instead of decreased. But it's so dramatic you'll know it when you hear it. It's like obscenity. I don't know how to describe it, but I know when I see it. Okay, so then palpation, palpating the right upper quadrant. So you're going to see this a lot. People are palpating the right upper quadrant. They say, take a deep breath. When you take a deep breath, the liver gets shoved down by the diaphragm, comes up against your fingers. You can't feel it already. And you see on physical exams, liver palpable on deep inspiration. Well, of course it is, because that's where the liver is. That's meaningless. What we want to know is what's the span in centimeters in the right midclavicular line. We're feeling in the right upper quadrant for a mass. That's why we're doing that test. Ascites. Ascites is free water within the abdominal cavity. It's just water, it's just in there. It's just floating in the peritoneal cavity. And it's almost never this obvious. This is either a pregnancy or ascites, and this is an 80-year-old woman, or man, so this is not pregnancy. Now, there are two tests for ascites: fluid wave and shifting dullness. I don't have pictures of these, so I'm going to demonstrate them. A fluid wave is just trying to figure out if you can create a fluid wave inside the abdominal cavity. And the way we do that is to put our hands on both sides of the abdomen and tap on it and see if you feel something hit your hand. If this abdomen is full of water, that one we just saw, I guarantee you that all you have to do is put your hands on both sides of it, tap it, and boom, you'll feel it. Boom, 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 boom. That wave will be transmitted through the fluid. Now sometimes the fluid isn't enough to create that. So you got a partner or you have a patient. Let's say you're not quite sure what's going on, so you have the patient put your hand there and push down so that you make the fluid a little tighter. Does that make sense? And then you repeat the test. When you do that test with multiple examiners, it's been reported that the sensitivity of that test, the fluid wave test, what I just showed you, for the presence of ascites, with the gold standard being the ultrasound, the sensitivity is 0.53 and the specificity is 0.90, which gives us a likelihood ratio of 5.3. Likelihood ratio negative is 0.52. So it's a pretty good test. Pretty good test. Shifting dullness. In medical school, we had a professor we called shifting dullness. Wow. Okay, so shifting dullness, how does this work? Dullness is a percussion finding, right? Percussion is either dull or tympanic. Dull or tympanic. So if you're percussing over water, it should be dull. Percussing over air, it should be tympanic. That make sense? That's really how this works. So you lay the patient on their back and percuss, starting in the midline. You percuss, or use the scratch test, either way, down like this until you hear the sound change. And you mark it with a pen. And then you roll the patient on their right side. And you repeat the test. Start up here. And if there's water in the peritoneal cavity, if there's water in there, the water will do this when you roll the patient over. And stuff that's floating in the water, which are small bowel, stomach, colon, hollow tubes with air in it, will float to the top, and the water will go with the gravity, the air will float to the top, and the dullness will shift downward. Does that make sense? So you percuss and mark where it changes. Roll the patient over to that side, percuss again, and see if it shifts. If the dullness shifts, that's a positive test, and it has a likelihood ratio of 2. So it's not as good as the fluid wave. If you only have time to do one test, do the fluid wave. But if you want a lot of practice, do them both. You don't have to memorize these likelihood ratios. You just have to remember how to use them. We'll do that in a minute. Okay, so palpation. Now, we're going to palpate the abdomen. There are really only 4 things you can find. One is soft, a soft abdomen. That's a normal abdomen. Guarding. Guarding is when I push on the abdomen and it sort of tightens up and pushes back. This has to be in a non-ticklish person. If you're examining a ticklish person, it'll guard every time, right? So if you're examining someone and they just keep doing this, they go, oh, I'm so ticklish, I'm so ticklish. Here's what you do. You say, put your hand on mine and follow me around. And the ticklishness goes away. When they take control and they have their fingers on your fingers, basically no problem. And you're finding the same thing you want to find. So, soft guarding, which is you push down and they involuntarily their anterior abdominal muscles contract. If they voluntarily contract, they're ticklish or goosey. And so you have to determine, is this a voluntary guarding or an involuntary guarding? Involuntary guarding of the anterior abdominal muscles means there's some inflammation or something wrong in there. Rebound tenderness is when you push down and let go. It hurts worse when you let go than when you push down. It'll hurt both, but you don't have to wrench down. You don't have to cram your hand down to their aorta. You just push down and then suddenly let go. And if they have peritoneal inflammation, it'll hurt worse when you let go. This is a phenomenon of peritoneal inflammation. It's so dramatic that there are a multitude of physical findings to help you decide if it's there. One is rebound tenderness. Another is they're laying down on their back. You can just tap their heels. And sometimes the inflammation is so bad in their belly that just tapping their heels makes it hurt worse. Another one that I like is to just put my hands on their iliac crest bilaterally and do this, just kind of move them back and forth. Jiggling their bellies. And if that hurts, they probably got rebound tenderness. And then there's rigidity. My woman from Woodward. When I felt her belly the next morning, it was as hard as a rock. And she had no bowel sounds. Rigidity anywhere in the belly is a sign of intra-abdominal catastrophe. No bowel sounds is a sign of intra-abdominal catastrophe. There aren't very many things, I mean, you've got time to worry about almost all the physical findings in the abdomen except these 2. Even with rebound tenderness, you got a little bit of time. You've got time to do a CT. With rigidity and no bowel sounds, they need to get to the OR fast. So it was about 6:30 in the morning when I felt this rigidity and there's no bowel sounds, and I called my friend the surgeon and I said, it was the first time, I've been in practice 8 or 10 years, first time in my career. I had the courage to say, Dan, this patient has to go to the OR, they have a surgical abdomen. There's a term called a surgical abdomen. A surgical abdomen is an abdomen that has to be operated on. You don't have to get a CT scan, you don't have to get an MRI, you don't have to get a consult, you got to operate on it. Since I can't do the operation myself, I've called someone who knew how to do it. Dan, this patient has a surgical abdomen. He chuckled, because I'm an internist now. What would I know about a surgical abdomen? So he came down, and he saw her, and he said, ooh, we got to go to the OR. So he takes her to the OR. It's the damnedest story I ever told, or heard. Takes her to the OR, and in about an hour he calls me. I don't go in the OR. I get rashes and papules and scabs and all sort of dermatologic things in the OR. And so he calls me and said, she's dead. I said, she died? He said, oh, no, she didn't die. But he said, I opened her up and her bowel is dead from the duodenum to the rectum. I said, what do you mean dead? He said, it's dead. He said, she's clotted off her mesenteric venous drainage. He said, I don't know what the hell's going on, but she's got a dead bowel. From the duodenum to the rectum, I'm going to take it all out. I'm just going to take all that out, throw it away, and then I'm going to sew her duodenum up to her rectum, and she's going to die. I'll meet you downstairs in a minute to talk to the family. So he completes the operation, takes everything out. Pretty complicated operation, got a lot of nerves and arteries and all kinds of stuff in there that I don't really know where they are because I didn't take Dan's course. And he sews her up and he puts her in the ICU. And we talked to the family and said, we don't know what caused this, but she clotted off the venous drainage of her belly. Her likelihood of making it is low, very low. I saw her 2 or 3 times that day. She looked fine. I saw her late that night before I went home. I came in at 6:30 the next morning. She had an NG tube down. She's got IVs going. I walk up to the bedside and she says, I'm hungry, get this tube out. Supposed to be dead. You are supposed to be dead. Thank you very much. She said, I'm hungry. I said, well, I can't take the tube out. We'll let the surgeon. So the surgeon comes by and sees her, and he's going, woohoo, I used to be non-religious, now I'm not so sure. And he says, I don't know why she's alive. And so by that evening, we took the NG tube out, and she took some fluids. I mean, that's the most bizarre thing I've ever seen in my life. Long story short, she got out of the hospital in a week, and she lives in western Oklahoma today, and she's a little chubby. She is a little chubby. How do you do that? She has 7 inches of duodenum and about 6 inches of rectum, and they're tied together. And the only thing she takes is an extra B12 shot every month. Go figure. I don't know how she does it. She had factor V Leiden. Did you study this? It was before factor V Leiden had been discovered. This was back before we drove automobiles and Jerry was a young man. Before factor V-9, so we worked her up for every clotting disease and didn't find one. She came back 20 years later and told me she had been diagnosed with factor V Leiden in Woodward. There are several points to that story. I tell it because, number one, time is a great diagnostician. Her venous clotting was occurring and it was causing abdominal pain. It was visceral in nature and we couldn't figure out where it was coming from or what was going on. She knew she was sick. She wasn't sick enough to do anything to, so we watched her. Time is a great diagnostician. The next morning she was sick enough to die. Number two, the clinician who prognosticates is a fool. Don't be caught. Don't be caught in this idea that you know what's going to happen, because you don't. And you might as well admit it, and you might as well admit it every time. I don't know what's going to happen. She's going to die. She'll be dead midnight. We went and told the family she's going to be dead by midnight. What? We didn't know. We had no clue. Right upper quadrant, that's where the liver is. That's where the gallbladder is. Ballottement. I don't know if this will be on pants or not. But if you put your hand in the right upper quadrant and you feel a mass, slow down. Slow down. Elderly patient, jaundiced, with a mass in the right upper quadrant. Elderly patient, jaundiced, mass in the right upper quadrant. What's your go-to? What do you think this is? What's the mass? A big liver cancer. You can't tell the difference between a liver cancer or a big liver by pushing on it. If you feel a mass in the right upper quadrant, blot it. Blot it is like, think of having a water balloon sitting on the table. If you just put your hand on it and pushed, the only way you would know that's water is because you can see through the balloon. But it doesn't feel much different than just tissue. On the other hand, if you bounce it like this, it'll bounce back. Solid liver or solid liver cancer won't bounce back. So ballottement is bouncing like this. And the only place I know of ballottement that works is in this setting. You know any other ballottement maneuvers in the physical exam besides the right upper quadrant?
Other than the knee, the patella.
Yeah, they taught that. I've never had a knee blot back to me. I think ballottement is misspelled here. I think it has knee in it. But anyway, here's why this is super important. If it blots, it's a dilated gallbladder full of bile. And if it's a dilated gallbladder full of bile, it means the bile can't get out, which means the gallbladder is obstructed. And because of this anatomy we talked about earlier, where the cystic duct and the hepatic duct and the pancreatic duct all enter into the same portion of the third duodenum, a carcinoma of the head of the pancreas can obstruct the cystic duct, cause bile to back up in the gallbladder, and it's a physical finding indicative of carcinoma of the head of the pancreas. Okay? Murphy's sign, that'll be on pants. Palpate the right upper quadrant and ask the patient to take a deep breath. If they have an inflamed liver or an inflamed gallbladder, it might hurt. Does that make sense? Taking a deep breath pushes the liver and the gallbladder up against your hand. Is Murphy's sign specifically for the gallbladder? Not for the liver. It's for both, but specifically I think Murphy described gallbladder disease. Liver edge is always measured in the right midclavicular line. I put auscultate for Fitzhugh Curtis. That's probably not going to be on pants, is it? Fitzhugh Curtis? Well, I'll just tell you what it is. Females who get pelvic inflammatory disease, used to be the most common organism for that syndrome was gonorrhea. Today it's chlamydia. So they get a chlamydia infection that goes undetected for some time. The infection goes through the body of the uterus into the fallopian tube and out the other end of the fallopian tube and gets into the gutter, into the peritoneal gutter, and works its way up to the liver and inflames the capsule of the liver. So now you've got a liver capsule infection, inflammatory response to chlamydia. All started in the pelvis, and they might not ever have had enough symptoms to seek care before this happens. Now, when this organism inflames the outside capsule of the liver, it's adjacent to the pleural membrane, and it's adjacent to the peritoneal membrane, and it sets up these inflammatory spindles of stuff that look like, I don't know, little pieces of white stuff. If you put your stethoscope, over the liver, over the chest, and have the person breathe, Fitzhugh and Curtis reported, listen to this carefully now, Fitzhugh and Curtis reported that it sounds like walking on fresh fallen snow. Ever paid attention to it? But it comes with the breathing. Right after I learned this, actually I saw a patient with this, had no idea what it was or it even existed, and was, like most medical education is done, I was shamed, dramatically shamed for not knowing what it was, and swore I would always pick it up again. And the next month, I was in another hospital and I was making rounds, and a young lady was laying there and she was having IV antibiotics for pelvic inflammatory disease. And she said she had right quadrant pain, and she had been vomiting and she was just really, really sick. And so I listened to the right upper quadrant and I heard it's you, Curtis. So when my attending came by, I presented her that morning and I said, this lady with pelvic inflammatory disease now has Fitzhugh-Curtis syndrome. He rolls his eyes. What makes you think that, Brad? Well, he has the auscultatory findings of Fitzhugh-Curtis. It sounds as if someone is walking on fresh, frozen snow when you listen to a right upper quadrant. He rolled his eyes. Yeah, you're dumber than anybody I ever met in the panel of Oklahoma. And we go to the bedside, and he puts his stethoscope on there, and then he looks at me and he says, he reaches over and he puts a crimp in the NG tube. The NG tube was on intermittent suction going. Why don't you take a listen now? Fitzhugh-Curtis. Now this won't be on Pants either, but it might be on my exam. Curtis. Fitzhugh and Curtis were academic gynecologists. They described this thing. The question is, how did Curtis finish his academic career? He was the head football coach at the University of Kansas. True story. Go figure. Okay, left upper quadrant. This is a tricky phenomenon. You're looking to see if the spleen is big. That's what you're really doing. In the left upper quadrant, you're trying to see if the patient's swimming. The spleen is sitting way up underneath the rib cage and should never be palpable. So regardless of what you do with your hand up in the left upper quadrant, you should never feel the spleen. Now, a couple of maneuvers are to reach with your left hand behind the patient's lateral chest and support it like this and push like this and tell the patient to take a deep breath. Sometimes with a big spleen, when they inhale real big and their diaphragm pushes down, it'll push that spleen up and just sort of tip the end of your fingers. It's a remarkable, subtle finding. You won't feel it without some maneuver like that. Another method is to percuss over the left lateral chest with and without a deep inspiration. So just like the other percussion phenomena, you've got your finger in between the ribs over here. Right there. And you're percussing, and then you say, take a deep breath, and you're listening very carefully to see if that percussion note changes at the end of inspiration. If it does, the diaphragm has pushed a large spleen up underneath your finger. Pretty hard to appreciate, but nonetheless, that's how you do it. Right lower quadrant, we palpate all four quadrants looking for masses and tenderness. Right lower quadrant is where we find appendicitis. Tenderness at McBurney's point is appendicitis. McBurney's point is somewhere down here. I can't remember how to define it anatomically. Do you know how to define it anatomically?
Halfway between the umbilicus and the ASIS, anterior superior iliac spine.
Okay. halfway between here and here. As a third-year medical student, I was taking my oral surgical exam, and it was an oral exam, and I was scared to death, and I was sitting in there, and this mean surgeon was asking me questions. He said, pretend I come into the hospital and I've got an inguinal hernia. You're gonna hear about this from McNeil next week, or maybe later this week. I got an inguinal hernia and you decide you're gonna fix it. What are you gonna do? I said, well, I'd start at Bernie's Point. He said, hold it. He said, oh, I think I'll find me another surgeon. He flunked. But Bernie's Point is appendicitis, not hernias. That's where the appendix is. Hernias are way down here, this is under here. I became an internist. Left lower quadrant. Okay, so what are we looking for? We're looking for masses. You got to worry about the pelvic structures, but mostly that's done with the pelvic exam. Kidneys, mostly kidneys are not felt, but we always palpate the CVA, this costovertebral angle. Everyone knows what that is? Now, I think I'll get to costovertebral angle in a minute. Here's another PANCE question. If you're palpating the left lower quadrant and it causes right lower quadrant pain, you have to worry about appendicitis. That's called Rovsing's sign. Rovsing's sign. Did I spell that right, Dan?
Yeah.
Yeah. That's a sign of appendicitis. You're palpating on the left and you've got pain on the right. That's another example of peritoneal inflammation. Iliopsoas sign, the patient's lying flat on their back, and you put your hand on their knee and ask them to extend at the hip. If that causes right lower quadrant pain, it's a sign of appendicitis. Obturator internist sign, you have them flexed at the hip, and then you rotate their knee laterally and medially, and if that causes pain, it's stretching the obturator internus muscle, and it's indicative of either appendicitis or a ruptured appendix with an appendiceal abscess. And what that means is that the appendix is causing inflammation against one of these two muscles, iliopsoas or obturator internus. Now, the costovertebral angle I want to talk about just a minute. We worry about the costovertebral exam when the patient has fever, high white count, urinary infection, and we're trying to figure out, is this just a urinary tract infection or is this pyelonephritis? Pyelonephritis means the infection's in the kidney. And we got to worry about that because if it's just a urinary tract infection, we give them some antibiotics and they go home, right? If it's an infection of the kidney, pyelonephritis, we put them in the hospital and put them on IV antibiotics. So we've got to figure this out. And there's no way to figure it out very well, except for how sick they are in physical exam. The books will all tell you to set the patient up on the table, put your hand over the CVA, and do that and see what hurts. That's a good way to get a bloody nose. If their kidney is inflamed, it's going to hurt like the dickens. The renal capsule is very densely populated with neurons, and it is sensitive. I think all you have to do is lay them on their back and put your hands underneath the costovertebral angle and just do that with your fingers. And I think it's a much more sensitive test. If that hurts, they're inflamed. If you do that under each other. It's going to hurt about half of you if it is, if you're just sitting there and you're normal. I think every textbook says to do that. I say don't do it. Pounding, not a good idea. Any questions about the exam? Okay, we've got two more things to do and then we'll be finished. We'll be finished way before 3 o'clock. First is, we've got a diagnostic test that I've presented. They are physical exam maneuvers, shifting dullness, and the fluid wave. And we've got to figure out how to use that at the bedside. So you've done a history, and you're worried that this abdomen's got water in it, so you do a shifting dullness test, right? And it's positive. I don't mean shifting dullness, I mean wave. A wave test seems positive to you. It feels like a wave's hitting your other hand here. And you know, or you look it up, just Google it. The likelihood ratio is 5.3. And you're, I don't know, 50% sure. 50%. Pre-test probability is one of three numbers. What is it? What are they? 20, 50, and 80. You're 50% sure. What is the pretest odds of a 50% pretest probability? There are only three numbers you have to remember to do this at the bedside. 0.25, 1, and 4. 0.25, 1, and 4. I'm going to say that until you're sick of hearing that. 0.25, 1, and 4. If it's 50%, what's the pretest odds? 1. So you take 1 times this likelihood ratio, which is 5.3, and divide it by
6.3.
6.3. You just add 1 to it. We can do it at the bedside. We can drop the 0.3, and we can do it in our heads. 5 divided by 6 is, well, kind of do it in our heads, about 80, 85, somewhere in there. We've taken our pretest probability by taking a history and looking at them from 50% to 85%. The only question now is 80 or 85% high enough to stick a needle in their belly to get some of this fluid to see what it is? If you're not comfortable with that, then you get an ultrasound, right? See if there's fluid there. But for our purposes, we've got to get comfortable with this pretest and post-test probability. And we've got to get comfortable with the fact that we can always do it at the bedside, which is why I keep bringing it up. You're getting close. This is something I haven't shown you before. What is the strength of a likelihood ratio? Excellent is 10, very good 6, fair 2, useless 1. Right? Okay. Any questions? Okay, we'll be through in about 5 minutes, but I got to tell you a story that'll demonstrate what I've just lectured about. 30 years ago, my 13-year-old son came home from school with a tummy ache. He was very healthy, very vivacious, good student, good athlete, good kid. Comes home with a bellyache, but he didn't look sick. He just didn't feel very well. Didn't play sports that afternoon because his tummy had hurt. And so we had dinner, and he didn't want to eat. He just wasn't very hungry. And his mother wanted me to examine him. I generally said, no, it's not my job. By this time it's 6 o'clock in the evening, so I'm thinking, well, call the pediatrician after hours or whatever. So I said, okay. So I examined him in a normal abdominal exam. His mother asked him 4 or 5 times if he had bowel movement. That's mother's job, make sure they had bowel movement. I asked him several times, did you get in trouble at school today? What, did you get in trouble? That's Daddy's job. Accusatory. I said no. So he went to bed around 8 or 8:30, and he still just kind of had a bellyache. His abdominal exam was normal. I waited till about midnight. I went and woke him up, and I said, "How are you feeling?" He said, "I just feel awful. I just have this bellyache, and it's just not going away." And I examined his belly again. It was normal. Maybe I could stretch it to say he's got a little bit of tenderness, but I mean, it was just non-localizing. About 4, he came in our room and woke us up and said, "Dad, something absolutely has to be done about my abdomen. It really, really hurts." So I examined him and he had point tenderness at McBurney's point. And I said, let's take him to the ER. So we got dressed, and on the way to the car, he vomited. And we got to Children's Hospital. I guess by this time they were doing CAT scans for appendicitis. And they did a CAT scan, he had acute appendicitis, and at 6 o'clock he had his appendix out. But I thought the story was my favorite story because I got to see the illness from the very beginning until post-op. And it does exactly what the textbooks say it'll do. At school, he started having visceral pain. This inflammation was inside the hollow tube that we call the appendix. It was inflaming the mucosa on the interior of the appendix. But he was getting messages to both sides of his brain, so he didn't know where it was. He couldn't say it's right down here. It's just a bellyache. And it stayed a bellyache until that inflammation worked its way through to the outside of that appendix, and now it's up against the peritoneal membrane. And now the pain's really severe because those pain receptors on the peritoneal surface are much more dramatic than on the inside of these tubes. And he said something absolutely has to be done, and he had tenderness at McBurney's point. And then he vomited. This noxious irritation of the nerves of the peritoneal membrane caused us to vomit. I don't know why for sure, but it does. And 2 hours later, he had his appendix out. So it just demonstrates exactly what I'm trying to tell you on the lecture. It was exactly a 5-minute story. Thank you very much. Thank you.
Thank you.